Let's start structural heart disease live case section 5, TMVL tricuspid. My name is Jung-Sung Kim, Yonsei University Severance Hospital. So in this session, fantastic and very innovative live case is prepared by in the St. Paul Hospital by lead by Dr. John Webb. And I would like to introduce four excellent experienced panelists, Do-Yun Kang, Michael Kang-in Lee, and Wojciech Wojakowski, and Sungwan Yoon. First, let's start the live demonstration. Is John ready to get started?
The case is actually going to be led by Dr. Anson Chung, who's a real expert in this. Our group has experience in the tricuspid with TriClip, and we have Dr. Rob Boone here who leads that effort. And I've been involved personally in the EVOKE tricuspid valve implant, which is also an excellent procedure. But today I'm not taking any role in this because I just finished a paravalvular leak plug closure and left out at the beginning. So I think what I'll do is I'll turn it over to Dr. Chung, who'll do the introductions and lead the case. So Anson, please.
Thank you. Welcome to Vancouver and good morning in South Korea. I would like to introduce you to the team today, and we lead by the effort Dr. Webb and myself, the cardiac surgeon, Anson Chung, Dr. Rob Boone, interventional cardiologist, the interventional fellow, Dr. Miriam Akadat. We have our scrub nurse, Rowan, and she's going to be helping us to finish the case. And we have our eyes, echocardiographer, Dr. Rob Moss, and our anesthesiologist, Dr. Ron Ree, Dr. Terry Sun, and Dr. Ron Lee, and the anesthetic fellow, Leon. I hope I didn't miss anyone. We have also the circulating nurse with Matt and Aaron in the background there helping us. We also have the team from Jen's Care with this Luke's tricuspid valve, and the engineer are preparing the valve for us. At this time, I think it's best to actually talk about the patient. Right?
Sure,
yeah.
Sure. I'll maybe get out of the way while you guys actually do the work. Yeah.
So Miriam is going to actually go through the patient with you and see if you agree with our plan.
Okay, good morning, everyone. So this is the case of Mr. S.J. So next slide, please. So he's a 77-year-old male with severe TR, and he has shortness of breath for at least a year. He's now NYHA3 with peripheral edema and heart failure related to this severe TR. So as a past medical history, he had 2 stenotomies with a previous mitral valve replacement in 2000, and then another surgery with 2 mechanical valves in the aortic and mitral position in 2020. He also has COPD and atrial fibrillation. So GFR is 69, and you can see that the BNP is a little bit high. He's otherwise totally independent socially. Next slide. So you can see on the TTE that we have a severe TR. Next slide. And on this TEE, you can see also that we have, most importantly, shadowing from the mechanical valve. So we're not able to really see well the anatomy of the tricuspid valve. Next slide. So it's also a difficult anatomy valve with a tricuspid anatomy, which makes it difficult for edge-to-edge repair. Next slide. Normal coronaries and high pressure on the right heart cath. Next slide. On the CT scan, you can see that the tricuspid annulus is very dilated with maximal diameter around 55 millimeter. And we can use also the CT to define the coplanar view that we're going to use today for the implant. Next slide. So we discussed this patient as a heart team. We thought that he was at high surgical risk because he had several previous stenotomies. He also has COPD. And we don't have any other transcatheter options for him. Edge-to-edge repair doesn't seem to be a good option regarding the poor imaging, the anatomy of the valve, and the coaptation gap. And the tricuspid annulus is too large for other devices. So today our procedural strategy is going to be general anesthesia. We have a main access, which is from the right jugular vein with 2 proglide as a pre-closure, and we plan to do a figure 8 at the end. We have a secondary access, which is a right femoral vein, 7 French shift there, and a right femoral artery, a 5 French shift. We performed already a right ventriculogram in the implant angle to define the tricuspid valve view. And we already positioned an extra stiff, Amplatz extra stiff wire in the PA. We dilated and inserted the sheath, and we're ready to implant the 30 to 55 millimeter Lux valve. Next slide. So just to give a little bit of details on the device, so it's a nitinol self-expanding tri-leaflet valve. It's going to anchor with a unit septal tongue, 2 subannular tabs. It's a 31 transjugular delivery catheter. We're going to use TEE and fluoroscopic guidance, and we don't need any pacing for the implant. Next slide. So we have a short video here, so maybe Dr. Chung can go through the steps.
Yeah, so this is a transrectal system, as you say, 31 French, lighter node self-deploy valve. This delivery system is quite good that you can multiple steerable, and the anchor mechanism we mentioned is non-radial force, I think, which is a key thing, not getting into AV block for tricuspid valve. And you can see earlier the septo tongue with a septo anchor is the main mean of anchoring this valve securely in place. And then the supplementary anterior and posterior tap subannularly also fixate the valve. You know, we have, you will mention a little bit about, you know, our experience in a second.
Sure,
and
next slide.
very good.
Anson, should we just get Rob here, if we can see Rob on the camera?
Yep.
Rob, do you just want to comment on TriClip for this patient? Would they have been a good candidate?
Sure. I think Dr. Aquadat said something about TriClip. I think that TriClip tends to be our default, but this patient really has very poor imaging of the septal leaflet. So we saw in the opening images that the transgastric views are quite nice, and being perpendicular to the coaptation plane would not be an issue, but then grasping the septal leaflets would be a big problem because of shadowing from the mechanical valve. So we didn't think it was a good option for this patient.
Yeah, and I just want to mention that we, all these cases, we go for a hard team process with multidisciplinary team approach to it. And we assess for patient, of course, for surgery, medical therapy, and the commercial available TriClip, or put the patient into our trial, the Illuminate trial. And then the 3 devices we have on the shelf to find the best possible treatment for a particular patient. So Miriam?
Okay, so regarding just the literature, we have a few cases with this valve that were done with a transthoracic, transatrial approach, so more invasive than what we're going to present today. Regarding our local experience, we have done 7 cases so far with very good outcomes. Discharge at day 1 is the routine. We didn't have any complication. And for those who were implanted more than a month ago, we have a follow-up that shows a very good improvement in symptoms and very acceptable and good echographic results with acceptable gradients and only mild PVL in all of them.
Great. Well, thank you very much. Well, I think why we, at this time, I think get on with the case, and I'm sure that you're all excited to see it. We'll bring the delivery system up, please. While we're doing that, I'm going to give you a little tour of what we have prepared for the patient. So if you could look at this in the right neck as a right internal jugular access. And we have already had a 33 French introducer sheath that has been inserted percutaneously onto the patient. We're going to put this, you know, we have a guide wire, Amplatz extra stiff in the PA, which guide us, the delivery system, into the right place in the beginning. So why don't we do that? And also that we have a metal holder for the delivery system, which is mounted onto the actual operating table or hybrid OL table. Miriam, you want to come over and give it a hand? Yeah. So just you remind it back in. I'll do that. Yeah.
So, thanks for your introduction. Very wonderful case. Is there any comment or question from the panelists?
Well, I have a question because many of the patients with severe TR have electrodes in the right ventricle. So is there any way this valve can be used.
Can we have picture-in-picture with Dr. Chung on the camera as well? I
Sorry, I
always
missed
have
that.
two images.
Yeah. So I missed that question. You would say that in what type of patient? Oh, pacing. Yes. Yeah. So we actually have multiple patients that we've done in the first round of it. 3 out of our 4 patients that at the initial implant actually has pacemaker. Some of them actually had AICD lead along with it. So it's actually RV and also AICD lead. And we did that successfully with very little paravalvular leak. It usually does lead a little bit around that pacer. So I just want to see you can see the handle that that me and Dr. Boone is holding. So this is a multi-steerable system, and it allows you to flex, extend, and rotate the actual valve prosthesis. So I'm going to actually go through that and then put it onto a floor, please. Thank you. Tension under the wire, please. So we ahead of time we did a right ventriculogram and give us some idea where the annulus is. So at this moment, you can see that I'm likely in the range of our mid atrium on the floor screen. And what I'm going to do is I'm going to start flexing it towards the annulus, the tricuspid valve. You can see that's a slight turn, and I'm going to go forward a little bit into the annulus. So at this time, it's best to actually put the system onto this holder, so I don't have to hold it the whole time in my hands, and make it a bit more stable. And actually, much more it's very similar to a clipping system, mitral clip system that mounted onto the patient's lower extremities. Very good. So now, the key part of any of this type of operation is actually get coaxial to the annulus. So we're going to talk to Dr. Morse and see where we are. What do you think, Rob?
Yeah, hi. Good evening, I guess it is, to everybody there. Yeah, so we've got our kind of main working view is probably going to be the X-plane view off the right flow, the inflow-outflow view. So that view. We also use the multi-view extensively, as we'll see in the case, especially for device alignment. So if I put the color on here,
so where do you think
it's a bit hard to appreciate now because of the shadowing, but there's a lot of tricuspid regurg there.
Mm-hmm. So from the initial look at it, I think I'm just probably not posterior enough. I think I'm about to have to go slightly more posterior, and probably have to go a little bit more further into the ventricle.
So I'm just going to explain off there.
Please, thank you.
Anson. So you look like you're anterior and septal there.
That's right. So I'm going to do in order to move posterior, you can zoom in on the handle, please, if you don't mind, a picture. And zoom in a bit more. So this holder actually allows me to advance the catheter. When we advance it towards the foot, that means I got to move the whole thing posteriorly. So which I'm going to do right now, and forward, please. That moves it more posterior and also further into the right ventricle. Yeah. So how do I look at that right there?
You've definitely moved more posterior there, Anson, but you're still fairly septal in your position.
All right. So in order to move from septo anterior, we can do 2 methods. One method, obviously, is to rotate the handle. You can just show my hand right here. So if I rotate towards myself, I will move it away from the septum. If I go away from myself, that will move the whole system towards the septum. So you said I'm too
you're
septal.
Good. Yeah, you're good on your antero-posterior position, but you're too septal in terms of your.
So I'm going to actually do a macro. This is more like a macro movement. So now I'm moving away from the septum. What do you think, Rob?
Yeah, there's a little bit of movement away from the septum now that we're starting to see.
Yeah.
Probably could be a little bit more towards the center of the valve, a bit more towards the lateral
I think
side.
what I could do is I can flex a little bit more, I think. Let me just do that. And then also move it a little bit more posterior to get into place. What do you think about that?
You still look relatively septal there to me. Do you want to see how it looks on the multi-view?
Yeah, please. So while he's looking at that, I think the patient's hemodynamic is very stable. Are we on any drugs, Ron? Yeah, we are actually no drugs at the moment, so we are quite stable at the moment.
Dr. Jung?
Yes, I'm here. Yep.
Yeah. So it's not that familiar procedure, yeah, for the audience and analysts. So I think it is possible. If it's possible, do you explain more some in detail of the anatomy?
Sure, that's fine. So yeah, so what we like to do is actually normally we can do this most of the procedure in the 0 degree, the 4-chamber view to have the long axis look at the septum and the leaflet, and then we can explain from that and look at the coaxiality of the valve. We don't really need to see the actual really minute detail of the leaflet itself, like a clippings, the procedure. All you care is that we get the system into basically middle of the annulus. And that's what we're trying to do. Dr. Moss is trying to guide me through using echo.
Yeah, so you're a long way from the middle of the annulus. You've probably come a little bit more posterior, but you're still very much hung up on the septum there.
So you want me to move away from the septum?
Move away from the
that's
septum,
right.
yeah.
So we could do that by a little bit more rotation. I'm just going to undo this system. You can see my handle. I'm going to rotate the whole system away from the septum. What do you think?
Still pretty septal there. I'm going to go back to the explain.
How about there? So Rob,
so you've got a lateral trajectory in a septal position. So still very hung up on the septum.
Take that. I'm sorry,
still
Rob?
very hung up on the septum there.
Okay, very good. I'm
So
just
have a
trying
look at
to.
that right-hand image
Yeah.
there.
So yeah, you better there.
Yeah, we're a long way from the center of the valve.
Yeah, it's okay, but it's not. Am I away more away from the septum?
Yeah, move away from the septum, I think.
Yeah. So let me just try that because I think I can manipulate this using take it off to the actual holder and get a little bit more coaxial plane up to it. What do you think about that?
Yeah, we're still pretty stuck up on that septum there. So looks like you're really right snugged up against the septum ends.
Yeah. So another thing we could do is, I think is we could take the wire out. Why don't we do that? And sometimes the wire actually divect us to a certain area that we don't want to. So let's just take the wire out. And did it help at all, Rob?
No, it hasn't changed.
It doesn't change anyway. So let me just do a bit more manipulation of this catheter and try to get away from the septum.
Okay, you move there.
Yeah, what do you think about there?
You need to come more towards the center. And you've got a very lateral trajectory, but you've got a septal position.
Okay, very good. So yeah, so what I could do, I can put it back into the holder. So we're gonna move this. I can extend this a bit further out. Yeah. Okay. So you think that's a bit better? I think this actually look a bit better away from the septum. Yeah.
Let's try and clean this up a little bit.
So again, we talked about earlier that, we need to, I think this is one of the major steps is to get the delivering system in the center of the valve.
Yeah. So
you don't do that, really nothing will work.
Okay. So you do look like you've moved away from the septum a little bit.
Very good. Yeah. So all we did is, what I did is actually changing the angle of attack by the rotation, first of all, and also the secondary to change the level of the delivering system where you enter into the septum.
Now you might find you've come a little bit more posterior than you want to come. So
you are too posterior or no? You want me to go more posterior?
No, more anterior. A little bit more.
Sorry.
A little bit more anterior.
More anterior.
You've drifted a bit posterior.
Yeah. Okay, so what I'm going to do is I can flex the catheter a bit more even.
It's looking a lot better.
Okay. So that moves it away from the posterior. What do you think? I think that's actually pretty good to me.
Okay, let's
yeah, so I'm going to do it. I think this is a pretty good. I think that what needs to do is actually go further into the ventricle.
Okay.
Because of course we don't want to expose the anchoring system above the annulus. So what we're going to do, so
Can we put up
is
the
to-
fluoro there on this picture in picture, please?
So can you count that? So this particular dipping system, can you onto my handle, please? For camera onto my handle. Thank you. Very good. All right. So I'm gonna follow, please. I'm gonna expand this catheter further into the ventricle. So you see that it's now slowly moving towards the apex of the right ventricle. I think that's pretty good in terms of the depth. What do you think, Rob?
I think that's very good.
Yeah.
And it does look more central on the TE.
Right. So the echo Rob, because I have to go between the two Robs. What do you think, Rob?
Now, let me
Echo
just
Rob.
go back to the explain here.
Thank you.
What is your target depth? The target of the device depth on the ventricle?
Yeah, so if you look at your fluoroscopy on your screen, so you see the particular, I'm not sure you can see, someone could put a pointer onto the fluoroscopy, it would be great. You see a sort of diamond shape, that's the septal tongue. I'm not sure you can actually film on, can you zoom on my finger or not? The best way of doing this. Yeah. Yeah, if you can actually see the screen, we're going to turn it around. Can you put it onto the perfect? Okay, very good. Okay, you see that? You see these two particular dot right there and there. That is the subannular taps. I want that to be below the annulus, which we have the plane. We have a line draw onto the screen to allow us to see the depth. Yeah. Okay. So actually, I think the depth is actually pretty good, in my opinion. So I think we are reasonably central. I mean, we can't get it 100% centrally, but I think that's decent. What do you think, Rob?
I think you've come a fair way posterior there.
Yeah, it's so the upper left image, it's posterior, the left-hand side of the screen, and the upper right image, the septum is on the left-hand side. So it's posterior and septal.
Okay, so I'm going to do, I can do a little bit of rotation, trying to again get it away from the septum. Yeah, so I'm going to actually rotate the whole handle away. Did it help? I don't think it did. What the other thing is I could do is actually go a little bit.
We'll get so you're right in the commissure there, Anson, I guess, between the anterior and posterior.
So how about now? I just move it a little bit more anterior.
Yeah, I'm looking at the 3D image in the bottom right-hand corner. So there it still looks like it's pretty posterior and pretty septal.
Oh. Okay, so I could do a little bit more anterior movement. Can you follow, please? So that, how about that?
Yeah, it's probably come a little bit more towards the center.
Yeah, I think this is pretty decent. I think we should expose the tab and see where we at.
Okay, you're still not really super central, but you're better than you were. That's for sure.
Yeah, yeah.
Okay.
I think that's actually not bad. I think I think we should achieve the ventricular portion. Okay,
it's definitely better.
Yeah, very good. So all this I actually uncouple the whole system, and this allow me to retract the actual sheath that contain the valve. So now we're going to
want fluoro up on the screen
fluoro,
for this?
please. Yeah, fluoro and echo. Can we have fluoro, please, too? And picture in picture. Yeah, please. That's great. Yeah, echo and fluoro at the same time. Very good.
So the first thing that's going to come out of the unsheathing is the tongue. So you'll see that diamond shaped thing that's going to be released here. It's coming out now.
And then you see two sort of rapid gear type of thing. That is just two subannular tap. So you see that they're projecting now towards yourself on the fluoroscopy. And I want them to be a bit horizontal like that. Oh, that. Perfect. So the key now is actually make sure that those taps are subannular. So this is again the echo Rob.
So Anson, you've gone really posterior again. So you're okay on the medial lateral side, but you've got a really super posterior trajectory there.
So I would do is I could flex the catheter a bit more. So you see that will work, but it doesn't seem to do that.
Just going to get at the phone there. Thanks.
Looks like you might have come away a little bit there. Yeah.
What do you think about that?
So still pointing very posteriorly.
Mm-hmm. Can you go to the
to the
zero
X-plane?
axis, please? Yeah.
To the 0 degree view? Or
Yeah,
the
0 degree
X-plane?
view. Yeah, right. 0 degree four chamber view. Please,
Okay.
thanks.
So, Dr. Chung,
Yes.
yeah, I think that what I understand, most important part is to target the central part of the tricuspid valve, and the other thing is coaxiality.
Yes. Yes.
Yeah.
Yeah.
So
yeah.
this is a very important part in this process.
That's right. Absolutely, you're correct. And you know, we spend a fair amount of time and try to do that. But occasionally, it's, because of the patient's anatomy, you can't really get completely the perfect 90-degree angle to the annulus.
So that's the reason why I think it's more comfortable to use a jugular approach rather than femoral approach. I think a femoral approach is very difficult to approach. Yeah.
No, we are doing jugular.
Yeah.
This is right jugular.
Usually, prepared jugular. Yeah.
Well, I was going to say, so it really depends on the delivery system.
Yeah.
And so for all of these systems, regardless of what you're going to use, you do have to be central. And then it comes down to the engineering of the delivery system. There are femoral systems that will do this, much like MitraClip can do this. But I think in this particular device, the jugular access is really good.
So, Echo Rob, can you find the anterior tap for me, please?
Okay. Do you want to go back to the 0? And
I think you had that in that view for a second there. Yeah, I saw that you just cut through it.
Maybe I'll go back to that other view then.
Yeah, yeah. The other view that you just had before this one, you did have the tap showing. So you see that? That's the tab right there. So can you put a cursor on the tab for us, please, Echo Rob?
Both of them. You're seeing both.
Right there. That's the tab. So definitely that tab is subannular. There's no doubt about that. So when we do, at this point, we like to capture the leaflet. So almost like a mitral triclip is that we will raise the system towards the atrium and try to catch it. So that's what I'm going to do. Oh, can you, can we follow and echo at the same time? Yeah, just, Rob, Echo Rob, just show me
just hold on.
So I'm just waiting the echo image to be in place before we, Oh, they're right there. Yeah, thank you. Yeah.
So Anson, you're not bothered by that posterior position at all?
I don't think it is. I don't think that's, I think as long as we can catch the leaflet now anteriorly, once we expand more, then we'll probably have better success.
I think we're pretty confident we're subannular with that tab there.
Yeah, definitely subannular, no doubt. I'm going to go more atrially now. And you can see that leaflet become a little bit more rigid. Okay, can you guys appreciate that on the echo? And I think now, I think I would stop there. Echo Rob, what do you think about the height of that implant so far?
Yeah, I think you're nice and subannular with that tab.
Yeah.
So it's hard for us to see both tabs simultaneously in this view. So I think that looks pretty reasonable.
Yeah. So I mean, it's always a danger that you want to make things perfect, which then you go subannular, then you have to resheath the whole thing and make it difficult. So what I'm going to do is only going to move another couple millimeter more atrially, and then we will do the unsheathing for the rest of the valve. Okay. Yeah. So right there, and I'm going to move it just like a little tiny turn.
Is the opening of the tap reversible or not?
Yes. So we can recapture everything. We can slide we pulled back the sheath to expose everything. And at this point, we could resheath it if we wanted to.
Absolutely. So not until the whole atrial skirt comes out completely, we can still resheath the whole system. Okay, I'm actually quite happy there, Rob.
Okay,
so I'm going to actually unsheath the valve, the ventricular portion of the valve. Yeah.
stay in this orientation for
Yeah,
now?
please, that'd be great. Thank you.
Yeah.
So now we're exposing further the ventricular portion of the valve. You can see the expansion there. We can do this very gently and under control. And what we want to see is make sure that the atrial skirt open above the annulus. Just like many of this, it doesn't matter TMVL or tricuspid valve, the valve usually self-adjusts about how you deploy. So I'm going to continue to unsheath the atrial skirt. And the images on echo is quite good. It's definitely I'm super angular on the atrial skirt. I have no doubt
Atrial
about
skirt
that.
looks pretty good there.
Yeah. So we just continue. So again, not until I fully deploy this, I can see we capture. So now I'm almost at the point of no return, which is now. So the atrial skirt is out.
You take a cine of this and it may be easier to see the atrial skirt, which is very, very fine.
Yeah.
But I think you see it better on cine.
Absolutely, you're up. Yeah.
Yeah. Do you want, are you ready for color yet or not?
Yeah, please. So at this point, we can actually still have a few maneuver to try to make it perfect. We can actually put the valve further into the ventricle or pull back more to the atrium. So we would like to see color just to make sure that we don't have much of a valve leak. And you can see that. Well, Rob, you want to tell us what you see there?
Yeah, there's some PVL in that sort of anterior position, which seems to be a common finding at this point in the deployment. So maybe I'll just get my pointer out and sort of indicate to people where it is.
So I like to call this the space invader view, where you have the arms, come out, completely. You can see me.
And if we're looking at the X-plane
to sit on the atrial skirt. Yeah.
Anson's dating himself because
I'm dating Mel Space Aliens or Space Invader video game. Yeah, I know. I'm getting old.
So I don't know if you want to try and come a bit more anterior with the device at this point.
I think what we could do at the moment is to go to the 0 degree, look at the septal tongue, contact with the septum, and then we determine what we need, how to maneuver this device.
So I think that's the key is now that the two tabs are deployed subannular under the anterior and posterior leaflets, the next maneuver is to move towards the septum and then deploy the septal tongue. And so we're pretty close where we are, but we'll confirm that with the next set of images.
So this system also has several things that we can allow us to have better septal contact, either rotating the whole handle. The valve could be rotated on itself up to 60 degrees. And also they have mechanism that actually push the septal tongue towards the septum and make a better contact. So, and this is all, the rest of this is all done under echo. So I'll just make sure that the echo, Rob could give us
so this is where we need to take a little bit of time. So
yeah. There, we just see if we can find the septum and the tongue itself.
Looks like, let me just go back to maybe the X-plane view. We'll have a look there.
Sure. On that particular view, I'm sure you guys could appreciate that the atrial skirt is super angular and is wide open. And we had the color there earlier, and we can see very little valve leak.
Okay, so we're starting to see.
Aha! So that's I think that is not too bad. I see you see the very bright part of it. That's part of the septal tongue.
Yeah, that.
Okay.
Yeah, there. That's the septal tongue there.
Yeah. So I mean, a bit away from it, no doubt. So I'm going to do a couple of things to improve it. So first of all, I'm going to turn release the tension on the septal tongue because it's held back by a little string, which I just did. And also I could do is rotate the handle mercifully to get that closer to the septum, or I can rotate it on the axis of the valve itself, which is a different mechanism on the handle. Yeah, I think I'm not having full contact there, huh?
No.
Yeah.
You're not in
So
contact.
I guess, what to do, I could do the macro first, which, this is the first step. So can you
Just go back to the
macro
zero.
view? What happened? No, you had a good view there, actually.
You want to go back to that?
Yeah, I think you were pretty good there, I think. Yeah, stop the fall for a second until he finds us.
It's when we kind of pushed in a little bit.
So again, finding, the, proper image to, before we do anything rush is having the key. This very relaxed operation, the procedure. We can take all the time that we want. Hey, patient's hemodynamic is excellent. I'm not sure you can see the monitor. Patient pressure is, 114 over 52. Set us nicely, and we on no drugs. I hope, no drugs at all.
It's difficult to image this because of the mechanical valve.
Yeah,
so there
no
is
doubt.
a fair amount of shadowing.
Yeah.
So thanks, Rob, for struggling here.
Yeah. If you can't find the view again, I would suggest to go back to the 0 degree. Oh, that's not bad there.
It's not, I think that's the end of the valve. It's not the tongue. I'm going to try the 0 again.
Okay, thanks, please.
But it did look like the end of the valve was right on the septum. So I think that's kind of reassuring.
So we still trying to find the best image. You can see that this is not the easiest case because we have two mechanical valves giving a lot of shadow for the echo. It's one of the reasons that we didn't think that we would like to clip this one.
So you can see that the shadowing right along the septum there.
Yeah.
Thanks, John. John has to go back to the cath.
Okay, no problem.
That may not be unreasonable there, Anson.
Yeah.
So I flipped it around, right? So it's.
So I'm not so sure. Oh, that may be, that is the septal tongue, I think. Though I think it's not the best image to.
Can you explain the structure of the valve in transesophageal echocardiography?
So the structure now you can see on the left upper, it was the right atrium, and you see the bright spot are the atrial skirt. Then you have a straight part, which is the body of the valve, and then with the septal tongue, a diamond shape device that extended about 2 to 3 centimeters below the body of the valve. And that has to be in contact with the septum, where the 3-point anchor is going to fire against it onto the septum. And that's the mainstay of the fixation of this particular device. So I think that's why we are spending time here to make sure that we have a contact there before we fire the anchor. Yeah.
And
so unfortunately, so go ahead, please.
The valve has the uniform size or many sizes?
So the valve has 6 sizes. So we can treat patient from 35 millimeter up to 70 millimeter annulus.
Yeah. And that's the key for this, for tricuspid regurgitation in particular, for all of the devices, the sizing is particularly important. And so this product has a huge variety of sizes, which makes it unique.
You want to go back to the other, the other one that you're actually seeing some septal tongue?
The one that I
prior to this, not the 0 degree, the other one that you have.
One where it's at a higher angle?
Yeah, thank you. Yeah.
Let me just see if I can bring it on better in this view here.
So on the fluoroscopy, you can appreciate the septal tongue. You can also appreciate the mandrel that comes through the middle of the device. And so on echo, both of those things appear bright. And so that's part of the issue, is trying to figure out where you are in terms of, you can see below the valve, and then there should be two bright objects, one that's against the septum and then the mandrel from the center of the device.
So and during this time, also the valve is actually partially working, so we're not obstructing flow at all. So again, the patient's hemodynamic is not being affected at all. So that's a bit better view. If you could show me a little bit more ventricular lead there, and that would be good. I think I could.
Well, Anson, this is Michael Lee from Hong Kong.
Oh, hi. How are you doing?
Hi. Thank you for showing us this excellent case. During tricuspid intervention, sometimes during tricuspid procedure, TriClip procedures, when we don't have good images, sometimes we might use eyes to guide us. What do you think of adding an eyes here?
Yes, absolutely correct. I think you're Rob Boone. We want to answer that.
Yeah, so we haven't used a lot of ice for TriClip, but definitely you can do it. I'm not sure about this because it's so far down, and you still have this, well, potentially the same shadowing problem just from the device itself, but it's not a bad thought. And the other thing is, can you use transthoracic to see the septal tongue?
Yeah.
So I guess either of those things are optional. We thought there was sufficient imaging here to see the septum. And so I think we'll just struggle a little bit further along, but I think that's a good thought, ice or transthoracic imaging.
I think
the problem for ice, I don't use a lot of it, but coming up from the leg, I guess you could sit it in the mid-right atrium and it might give you enough imaging.
So I think, Rob, if you can give me some kind of long axis that's showing the septum, what I could do is I can try to rotate the valve towards you to get to the septum. So just show me the view and see if I can manipulate the device to you.
Okay.
Yeah, like that there. Yeah, a little bit more septum. Yeah, right there. So I'm going to try I'm going to manipulate the device towards you.
Yeah, let's see if we can see something here.
Yeah, if you could not to deviate from where you are. So I'm trying to rotate it to the system macroly towards the septum. You see that the septal tongue will come in play. Yeah, you're not cutting through the middle of that device, Rob.
No, I'm trying to show you the septum, I guess. More.
Yeah, show me the septum and just cut through the middle of the device. And then I think that I was trying to find you. Yeah.
It's kind of pushing in and out to try and.
Is there any anatomical minimum length of the ventricle or the distance between the annulus to the apex that may influence the use of the valve?
Yes, absolutely. That's correct. I think, we like to at least have the length of the depth of the right ventricle at least 35 millimeter minimum. Longer the better, because you want more room to maneuver, no doubt. The other thing is that if also the right atrial size is also matters because it depends on how far the device going to travel to the annulus. Huge right atrium sometimes could be a difficulty. We've done a couple cases on Tuesday, and then one of them had a post-transplant patient with a huge right atrium that took us a while to actually get into play, but it's still possible to do.
There can be some. I think that there can be some risk of the RVot obstruction in this procedure, and evaluation of the RVot in this DVR patient would be extremely challenging. Then how can you evaluate or avoid?
So right ventricular outflow tract obstruction is not really a problem with any of this type of devices, because if you look at the actual anatomy of the right ventricular outflow tract, it's really much parallel to this, unlike the left ventricular outflow tract, which is almost a 90-degree angle to it. So this actually is never have, I don't think there's a problem. We look at CT, obviously. CT is part of the assessment that we do preoperatively. And so far all the patients we screen have not even a patient close to having that problem.
Okay.
Yeah.
Just going to see if I can.
Yeah, so we're still
Try
just
something
trying to find a better image to show the septal tongue.
We haven't done this before, but what about the transgastric line?
Yeah, that's what I'm working on there.
Yeah, okay.
Is that not it there?
So we try a
It's gonna-
different
it's gonna
angle
try
of
and-
tech for the fluoroscopy with the echo. Once we find that, actually, there we go. Okay, very good. That is such a good view. Can you stay there, please? Oh, perfect. Okay, you see that on the echo screen. You see the very bright spot in the I guess towards the source of the echo. That is with the septal tongue. It's actually well pretty close to the septum.
Yeah.
I think I can improve it a bit better by a little bit of rotation. So stay there, please, Echo Rob.
Yeah.
Yeah. I'm gonna rotate this system towards the septum. There, I think there's better contact there, no doubt. Stay there, and then I do another maneuver. Is to actually push the needle, the firing of that particular anchor, and that actually could push the septal tongue towards the septum more. So I'm going to do that now. You can see the fluoroscopy. The needle tube is coming out, and then it's curved and then push it against the septum. So how's that, Rob?
So we've still got a bit of intermittent kind of contact there. Let me just see if I can. There.
If that doesn't, give you the full contact, I can always retract that. I can rotate the valve on its axis actually towards the septum. So that's another maneuver I could do. And this system is allowing me to do that.
I think this is the pusher here.
Mm-hmm.
So I'm not actually sure that I think we're seeing the end of the valve,
Yeah.
but not actually the tongue.
Is it possible you go
Yeah,
a bit
that's-
more deeper on the ventricle for
Yeah,
that particular?
That's what I think. I think that's the end of the valve. I don't think that's the tongue, Jensen.
So the two bright spots in the middle, one is the pusher and one is the mandrel.
Well, I could always pull the the needle, the tube back first.
There, that's the needle. Stop there, Rob. So Anson, do you want to pull that? Because I think that may be the needle tube.
Okay, so I'm going to pull that back, the needle tube. I'll pull that back a little bit. Okay, right there.
Mm.
So that's the end of the delivering system, actually.
Yeah,
this is the
that's-
delivering
yeah.
system.
Yeah.
So we actually not seeing the septal tongue very well. So
No.
I'm gonna actually try to rotate this. You can stay on that view.
I think. Let's try and open it out a bit more and see if we
Now,
can.
I'm actually rotating the valve now towards the septum. Right there. That's the septal tongue right there.
I think that's
Yeah.
it. That's the edge of the.
So you could try again with the pusher and see if you can identify.
I'll go higher up on the angle. See if we
Yeah,
can-
please. Could you just stay there for 1 second?
Okay, sorry.
Yeah. So there, I'm gonna just put it down. I'm gonna put this the tube out again, so you can see if that actually will. Yeah, there you go. No, I don't see that. No. Yeah. Yeah, we're not seeing the septal tongue very well on that particular angle that you have there.
Okay, let me just go back down the angle, see if I can see. Okay. Well, we know where the septum is, so let's try this.
once you identify this, the rest of the procedure will take another 2 minutes.
Yes. For
Or
anyone,
less.
for anyone that's been involved with the mitral or the tricuspid clipping, this is unfortunately part of the game. Is waiting for the
Oh, I'm
images,
seeing the septum
but it's
there, right?
definitely worth doing.
So I figure if the cursor's there, it should bring it. That's where the septal tongue should be on that right-hand image, because I'm steering away from the valve. So can you see that there, Anson?
Wait, can you put a cursor on it so I can, so tell me what you think there?
So I think that this is the septum here.
Yeah, yeah,
And so he's put the X plane through it.
yeah,
So we should be looking.
So I'm seeing the septum there, right?
yeah, yeah.
And I'm putting the X plane through where the septum and the valve are close together. And I think that's the tongue there in the right-hand image.
You think this is the tongue he's talking about? That is touching there?
Yeah, that's what I think he's talking about.
Can you
So
indicate the septal tongue?
Yeah, so yes, yeah, so right there. Yeah,
Oh, yeah.
okay. So if you can stay there and see if I push the tube in further and then see if it's actually better contact. So yeah, if you could just stay on that particular image and I'm gonna push the, yeah. You know, now I'm pushing this in to stop. Thank you. Yeah. You think that's a better contact there? I see actually the septal tube. Actually, you make it much brighter. You see that? That's a septal tube that is very actually, I think that's pretty good there. If you can just show me a little bit more of the actual septal tissue. And I want to make sure that is have real good contact to it. I think it's definitely contacting.
I'm not 100% sure.
Yeah.
I think you can see the tongue there if you can.
Yeah, I think if you quickly go back to the 0 degree, please, if you could.
Okay.
Yeah, thank you.
It is really a tour de force in terms of the echo image.
There it is.
Okay, there you go.
There.
Yes.
Okay,
Yes.
very good. So can you put a cursor for the audience, the panel there?
Yeah, if
To
I
show
can
me
let
the-
go of the probe for half a sec.
Yeah, yeah, I see.
This is,
Could someone else help Rolf to do that?
There
Yeah,
we go.
that, right
That's the
there.
septal tongue right there.
Yeah,
There you go.
okay, phew.
All right. Yeah.
I
So
think
it's,
finally we can be confident. But can
yeah,
we,
so it's actually contacting the septum.
It is
because
actually
you might be
contacting the
seeing it
septum.
in and out because of the shadowing of the mitral valve, but I think I'm pretty confident that it's in contact. So can you stay on this particular view, please? And we're gonna do cine, and we're gonna fire the anchor. So one second. Let me just do the safety lock first. Take that out. Very good. All right. Well, this is take a split second. So echo ready and cine. So I'm gonna fire now. The anchor is in. Very good. Okay,
it's
stop
looking
that.
good. It's kind of looking good.
Okay, so I'm gonna do is I'm gonna actually take the
Very hard
unlock
to see, but
the,
it looks like it's attached to the septum.
release the anchor, and then I can pull the septal tongue back, the needle tube back. We can see the handle there. I'm just gonna pull that back away from the valve. Yeah.
So now on fluoro, you can see that the septal tongue and the anchor are moving in synchrony.
Can you put a cursor on that to show the the panel that is the tongue is actually the septum are
Kind of
together?
midway between a short
Right
and long
there. Right.
axis.
That's beautiful. Okay, so I think we're pretty good. I think I would like to
Yeah.
actually release the rest of the valve.
Yeah.
All right. Can you go for
God.
4-0 or C doesn't matter?
Stressful.
Very good.
Okay.
Unlock this, and then we'll release the valve. The valve is fully released. Then I'm going to retract this. 4-0, please.
Slide fluoro.
Yep. Thank you very much.
Yeah, the valve's looking nice and solid. That's a really good sign.
Yeah. Very good. Now I'm going to
Very good
resheath
answer.
this. I'm going to resheath the whole system. So, but definitely, the delivering system is away from the valve. I'm going to go and unflex. There you go. Flex more. There we go. Yeah, there you go. The whole system's now resheath. Very good. Oh, there you go. I would make it too tight, and it would bend it. Very good. Rob, Echo Rob, you want to go give a tour of the first, freshly implanted valve while we take the system out?
Yeah, okay, so we've got that right ventricular inflow outflow view on the left-hand panel, and I've got the color on, color X-plane, and there's really very little PVL or competitive flow there that we've seen so far. It actually looks like a very good result, and the anterior aspect of the valve is pretty solid. It's not moving very much, and that to me is a pretty good indication that the septal anchor is nicely secured there, or that the septal tongue is nicely secured. So so far it looks fantastic. I'll see if I can get some 3D imaging up.
I think in that particular image you have right there. Would you like to put a cursor on the actual subannular tab that you can see visibly quite nicely?
Okay, yeah.
Yeah.
Perfect.
Right there, yeah. So that is the anchor, one of the subannular anchor, the anterior one. And then above that is obviously the atrial skirt. Thank you, Rob. And there's hardly any leak, huh?
That's perfect.
Yeah, it's a very good result,
Looks really
actually.
great.
Yeah.
Yeah.
So I mean, I think that Dr. Boone does a lot of clipping, and they have very good results. But sometimes you do have a little bit leak, not completely elimination
we
of
do
it.
accept a less than perfect result for
That's
the
right.
mitral and
Dr. Chung?
tricuspid
Yes,
transcatheter.
please.
Yeah, I have one question. Before releasing the device, I think don't you need to check some right ventricular function? Because sometimes, as you know, after TVL, some patients have some serious problem with the right ventricle.
Yeah, absolutely. Yeah. So this is a very unpredicted area that we all talk about to look at what right ventricular function is at least adequate if we close the leak. People have different formula, looking at TAPSE, looking at right ventricular ejection fraction, looking at right ventricular volume, combined with the assessment of what existing pulmonary hypertension they have. So actually, it's highly unpredictable. Now, I'm also a transplant RVot surgeon, but I've been looking at right ventricular function post RVot or post transplant for all these years. I still do not have a good grasp of what or formula, let's say, that to predict who does well, who doesn't.
Yeah, I don't think there's one particular thing. People who talk about the PAPI, and particularly in transplant, is predicting RV dysfunction. I don't think there is one particular thing that we can hang our hat on. And I think that if people have severe RV dysfunction, then doing anything like this, I think people have to be aware that there is a possibility of deterioration in hemodynamics. But for all the patients that we've done with these valves and with clips, we really haven't seen that as a clinical problem.
Yeah, actually, majority of them has improvement so quickly.
Yeah.
With quickly, renal function improvement. Majority of our patients have a GFR less than 25, and they will actually have improvement of that. And we had, so far, short-term result. They're actually encouraging. So anything else you want? Anything to add, Echo Rob, or is that from that imaging that you have there?
No, I think we should all go and have a nice cup of tea.
A coffee.
Yeah.
Yes, that's right.
Is there any question from the panelists for this procedure? So I think we have 10 minutes left for the live demonstration.
Yeah, so I mean, I'd be happy to answer any questions that you have, and also also seeing the beautiful 3D images Dr. Moss showing you right there.
Actually, in this procedure, go ahead.
Screening failure rate for this valve. How many patients actually end up having the valve?
Well, so far, we actually, for this particular device, so again, you remember that we talk about that we screen patients for all devices, including surgery. And if they are not candidate for a commercially available like clipping, Then we will assess for investigational devices, which we have 3. We also, like to, explore, because we don't know which one is the best so far. I mean, this is quite early on this particular field. And we will screen them. And what we do is we look at the best devices.
Yeah.
Now, in this particular device, the screening failure rate is very low. So out of those, the number of patients that we sent so far, we sent about 18 patients for assessment. We have only so far 1 rejection. Due to, I think, mainly because of the number of sizes available for the annulus.
Yeah.
So the 6 sizes cover a range from 35 to 70 millimeter, which is a big wide range, which other devices we don't have.
No.
I mean, we can talk about the devices, we've been published already.
Yeah.
RVot, for instance, have 2 sizes.
3 sizes.
3
So
sizes
RVot
now.
has
Yeah,
a
now
third
3
size.
sizes. They have 2 initially, and now a first size.
Yeah.
And bigger size, I imagine, to cover the biggest annular size. Now, the other thing I think is important is that the patient that we have done so far, a good portion of them had pacemaker leads going through it. So one of the, of course, the danger or problem with anchoring any devices is having those leads interfering with the anchoring mechanism. So we on CT, we also look at where the septal tongue is entering, and would that be a problem with that? So far, we have never haven't encountered a patient that is not suitable for this particular device.
Yeah.
Anything to add, Rob?
No, I don't think so. I think that one of the issues is getting into the RV. And so it's very hard to steer down there. And if there is occasionally we'll see patients that have a redundant wire within the atrium or a wire that circles around the top of the annulus, and that theoretically is a potential problem. But I think as soon as the pigtail's in the RV, then I think you're kind of home free in a way.
Yeah, that's right. Yeah. So again, go ahead, please. Yeah.
Oh yeah. If there is some perivalvular leakage, then how can we treat this kinds of valve?
Yeah, so this is a right ventricular side, right? As you say, you have a little bit mild perivalvular leak is really not sufficient to actually to warrant any treatment. So we just leave them. We just observe them. See how the clinical status is. Because having a small leak compared to, let's say, a left-sided device, left side is much higher pressure. So you might end up giving a small leak, not having hemodynamic significance, but you might have hemolysis.
This has a massive skirt on the atrial side, which really limits our ability to do anything to a paravalvular leak. But that being said, it is at the RV, and even after MitraClip or TriClip, we see a little bit of leak is probably acceptable.
Yeah, and also that you can, that theory of having a bit of blow off may not be a bad idea. But again, hemolysis is not going to be a problem here with very low flow across that. Yeah,
Rob Moss wanted to say something.
Yeah.
No, I was just going to say, I think the configuration of the skirt would make a conventional plug approach to PVL pretty challenging. In this case.
I think it's not possible. I wouldn't want to try.
And so this device had been implanted in a thoracic route for the right atrium, which we also done here in Vancouver. But majority of those cases were done in China. So we actually have been noticing, having follow-up echo on those patients. Once the endothelium go around the skirt, those perivalvular usually it was slowly disappearing. So, we really not really concerned about that at all.
So after the procedure, what is the strategy of the anticoagulation or antiplatelet?
Yeah, it's a great question. So majority of our patients are in atrial fibrillation pre-op. So we will actually restart their whatever home therapy they have. If they are on NOAC, then we will start on the NOAC pretty much the next day. In addition, if people are on warfarin instead of a NOAC, which we start on warfarin, the home dose. So we have not actually, unless patient with coronary artery disease, we have not actually started them on aspirin.
Yeah, and so I think that we'll learn over time. Patients will get routine CTs at a month and a year, and so we're looking for any evidence of valvular thickening. And so we'll monitor that over time, but for right now, I think we're going with the majority of them with the therapy that they're already on.
Yeah. So in addition, so the inner portion of this valve is 30 millimeters, quite decent size, and it's good flow around it. The gradient is very low. I mean, also look at it, usually between 2 to about 4 in majority of the cases. with good flow around it, hopefully that they don't get thrombosis. But again, this is any biological valve had that chance of thrombosis. I mean, definitely if they're not on anticoagulation pre-op, we generally put them on warfarin.
Yeah, I said home.
Anson and Rob, if the patient requires like pacemaker, ICD, or even CRTD in the future, I guess it is still doable. Am I right?
Absolutely. I mean, this is just like any other biological valve that we implanted surgically. You can put a endovascular wire across it. I don't think it's a problem.
So we've had the other devices that we've used. Some of the patients have required pacemakers post, and yeah, it's somewhat concerning, but it's feasible to put a wire through the valve just like with any other device. And then there's always epicardial wires or CRT wires, or there's lots of options.
Right. And in this particular device that does not require any radial force fixation, and also the septal anchor is actually away from the conduction system. Out of the 35 of a patient that in the transthoracic ratio implant group, and also our so far, 8 patients now, we have not seen a single pacemaker requirement, a new pacemaker needed. In addition, I should also mention that Chinese, this is a Chinese engineering valve, and had implanted in China transjugularly a few cases, and since we've done the most so far, but that they still have none of them require pacemaker. Just before we go, actually, I wanted to show you something that actually very interesting that I think we partnered with one of the 3D printing company. So you can see that on the screen right there. So this particular, that we do that, a lot of people say, well, what is 3D print does anything? But actually, with a tricuspid valve, I think it's important to see where the angle of attack. So I would actually preemptively think how much angulation I require. In addition, the septum. Septum is actually not a smooth surface on the right side, and you could be lumps and bumps, and also it could be slanted. And that gives some idea what kind of rotation I might need to make in order to get into contact with the septal tongue to the septum. Now, we did a patient 2 days ago with 2 pacemaker leads around it. And that particular case is very useful to help me guide myself away from those pacemaker leads. Now, the future of this particular using of this device is actually we like to actually mount this onto a training apparatus to let the physician, when we go proctor, have them train that particular to deploy that device on the actual patient. So I think that's the actually most utility of this particular 3D printing. Now the other thing is that it's not rigid, so this is printed on a more malleable material, which is mimicking what we see the tissue that we see intracardiac tissues. So I think this is something useful. I mean, maybe the only time I would say that 3D printing is actually sometimes some usefulness, because all the other time I say it's useless. But this one I think particularly maybe have some utility to it.
So I'm not sure how much time is left, but I really like to give some credit to the Echo folks, because as you saw, that's a challenging case, but we really can't do it without good imaging. So so thanks a lot, Rob.
Absolutely, thank you, Rob. Yeah,
Got me sweating there.
well, they are our eyes, so without them actually I can't do anything. Yeah. Any other questions on the panel? I think
Dr. Anson, this is Dr. Sohan Yoon from Cedars, Cleveland.
How are you? I've seen you for a long time. Yeah.
So I've seen the other tricuspid valve replacement cases with Edwards devices. So when I was in Cedars, so there's some patients had a big hemodynamic changes because they have a lot of volume overloaded. Immediately after the procedure, the procedure get little with the regurgitation. So have you ever, what type of the hemodynamic changes have you encountered with this procedure?
Well, surprisingly, all of those, I don't know about this one, the 7 patients we have done here, actually they have improvement immediately. They actually diurese much faster. And there, we look at the echo, the right ventricular function has not deteriorated at all, which you might think that sometimes could happen. I think that's, one of that maybe is due to our maybe selection criteria.
I think that the real key for this is very careful patient selection, and also before the procedure that they're as euvolemic as possible. So they're not in heart failure, they're not fresh out of an admission. These patients are all stable. The ones that we've done are all stable outpatients that are as euvolemic as possible.
Yeah.
And so,
So,
I don't think that's where we're
absolutely
going to see
correct.
any.
And then, you know, one
Got
of the
it,
patients
got
we
it.
did 2 days ago, he was actually in severe heart failure. Actually, I admitted him on inotropes actually for 10 days prior to the procedure to get them to a euvolemic state prior to me putting the device in. And he is actually a pre-dialysis patient. His GFR was 12. After all this improvement, actually GFR went to 20, well, which is still not very good, but it's better than 12. And he's actually, you know, now diusing is quite well. We might save him from getting dialysis. So you never know. But I think that's the hope. Yeah. Yeah.
Thank you. Thank you.
Yeah.
So it's almost time up. Yeah, thank you. Very innovative and educational live case and fruitful discussion on TM tricuspid valve implantation procedure, which is very interesting. It's very innovative. So the scheduled time is up, and we'll wrap up today's session. And thank you for all speakers and panels and audience who participate. Thank you.
Thank you very much.
Thank you.
Thanks very much.
Thank you.
It was really
Thank you.
great. Yeah.
You have a good day.